We start the race here at 10 o'clock. We are talking about Medicaid, Medicare, and D-SNPs. What happens behind the scenes? I'm familiar with all, if not most of you here. So, hi, I'm Randy Lober, Growth Marketing Manager here at Action Benefits. And part of my passion, part of my job is helping you all understand like all this crazy landscape that we work in. We know, you all know that living with like one government program is pretty tough, Medicare. And then when you throw another one in, Medicaid, things can get pretty messy pretty quick. And if you don't know how to advise your clients and work around some of those inner workings, things can get messy for them pretty quick. Joined today by Chelsea Gomez, our learning and development specialist, who is also my partner in crime. Chelsea, formally say hi to the people, please, before we get started.
Hey everyone, thank you for coming. I see we have some March Madness winners in our midst today. So thank you for coming and thank you for spending some time to help your clients get a little bit better of an understanding of how their Medicare, Medicaid work together to create that D-SNP that they are enrolled in. I know I have family members who are enrolled in these, so I definitely understand from both a personal and a professional level how difficult these are to navigate. So I'll be the one answering your questions in the chat. So please feel free to ask anything you would like, and I will answer your question as soon as I can. Otherwise, Randy, take it away.
As long as it is D-SNP related, that's all we can do here today.
True, true.
Um,
Caveat,
True.
yes.
I should also mention, as you take a look at our training calendar, which will pop up shortly after you leave here, we have this session, which you're in, which thank you all for coming. Appreciate spending the time with you. We have a session 2 weeks from now that talks about whether or not D-SNPs are always the right fit for dual eligibles. Today is really a deep dive into how these two programs, Medicare and Medicaid, work together. In 2 weeks from now, we'll invite you back to join us, or at least to register so we can get you the recording of walking through that decision tree of does this really fit the person sitting across the table from me? So I do invite you to come back for that session and not to skip over next week where we'll talk about VA benefits and how they interact with Medicare here as well. All that said, how would you describe your experience in the D-SNP market? What do you know about them? Are you well versed in D-SNPs? You know everything about them here. Have you written them before, but you don't know the guts of how they work? Do they make you nervous, or are you just a real pro and you just want Chelsea and I to get out of the way and I'll let you teach the class? Either put the letter or give a few notes in the chat. We'd love to hear about your progress here.
I do definitely understand where B and C, Emily, I'm glad that you put that answer out there. I do definitely understand where people can feel both ways. Like, yes, I've written them, yes, I understand them, but they still make you nervous because it really is like coordinating to an apples and orange, right? Like it's a federal program, it's a state program, it's different from state to state, especially if you work with different states. They have different rules. Oh my goodness, like do we
Yeah.
have the extended Medicaid? Like I understand definitely. So you can sell them and be nervous about them at the same time for sure.
Yes. And we'll make this clear a little bit later. We do have some friends and partners, even on this call, that do write business in multiple states with us. Today's session, because the bulk of our agents and the bulk of the members we help you serve are in Michigan, is focused on Michigan. But I'm happy to talk any other state with you in a one-on-one basis should you choose. Anyway, what we'll do today is three big things. We will define Medicare and Medicaid programs. Sounds simple enough, but so often in our industry, there's all kinds of acronyms, there's all kinds of words. People say one thing when they really mean another, and this is about insurance, and it's also not about insurance. Lots of different things to know here. We'll take you through some of those terms and make sure we're really rock solid on those. We'll also talk about Medicare savings programs, or MSPs, that really help guide that D-SNP eligibility. And we'll talk about how Medicare and Medicaid partner to pay for healthcare for dual eligibles. And that coordination between the two programs can be both your beneficiary's greatest assets as well as one of their biggest headaches. And so we'll talk to you about how it should work so you can help your clients fix things if they do get broken. So let's talk about a few terms right here at the top. Medicare is your lifeblood. You know that Medicare is health insurance for those age 65, those with certain disabilities, or who have collected your SSDI for 24 months and are eligible in the 25th month of SSDI. those with ESRD or ALS. No need to spend a lot of time there. Medicaid, we should, to be clear, is health insurance for those with low incomes. In Michigan, that is anyone up to 138% of the federal poverty line for their household size that they live in here. So so a household of one has a different FPL than a household of two, than three, or so on and forth. And that becomes really important in Medicaid calculations. Maybe, for example, you have a household that you're serving where you've got your client who's 65, you've got their spouse who's 65, and then you've got their adult child who's still living with them in his 30s something or 20 something. That adult child's income can count toward their Medicaid income and push them over the threshold for Medicaid eligibility. But the real big things I want to make sure we take away right here are Medicaid savings programs. Anytime we talk about an MSP or Medicare savings program, these are things like your QIMBYs and SLIMBYs and all those sorts of things, which we'll talk about later in today's session. Know that they are not Medicaid programs, but they are a set of benefits administered by a state Medicaid agency, and eligibility for those programs is dictated by both income and asset tests. This is important because oftentimes, even when you talk to carrier reps, they'll say, well, what level of Medicaid do they have? And that's really not the question we should be asking when we're talking about D-SNP qualification, D-SNP eligibility. The better question to ask is, what Medicare savings program are they currently enrolled in? Because you can have a Medicare savings program and not have Medicaid. We should also talk about Extra Help. Extra Help is not a Medicaid program, but it does help pay Part D costs. Extra Help is actually administered by Medicare. Also the low income subsidy program helps pay Part D costs, and it's separate from those Medicare savings program, exists outside of it. Although eligibility for one is a pretty darn good indicator you may be eligible for the other, but there are some cases where you're not. And there are some cases where you're not automatically enrolled, and we'll address some of those here going forward. If we want to talk about the general order of operations for how someone becomes eligible for a D-SNP, we would talk about the flow chart we laid out here on the slide here for you. First thing is, of course, if someone's going to be eligible for a D-SNP, they've got to be eligible for Medicare, and they've got to enroll in Parts A and B. At their core, D-SNPs are just like any other Medicare Advantage product. So they've got to live in the service area, they've got to have Parts A and B, and then we're on the right path here. Third hurdle we got to clear is, have they applied for a Medicare savings program through their state? So through here in Michigan, you'd use the Department of Health and Human Services or mibridges.com to enroll in or apply to Medicare savings program. Enrollment is sometimes automatic, and I want to emphasize the sometimes because it should be automatic if your person received Medicaid before they came on Medicare, but sometimes it's not the case. So when in doubt, there's no cost, there's no harm in applying, does not hurt your client if they apply. Always advocate, taking that proactive step and helping them, find mibridges.com or their local local DHS office and apply there. Fourth thing we want to do is apply for the low income subsidy, because that's the part of Medicare that's going to help take care of their drug costs and bring them down to zero or near zero when they enroll in a D-SNP. That enrollment is done through Medicare or the Social Security office. So you can go to ssa.gov and apply for LIS or the local Social Security office, although appointments are sometimes 3-4 weeks out. Generally speaking, for most Medicare savings programs we'll talk about here today, they will automatically be enrolled in LIS if they have a Medicare savings program. However, because we've got federal government program, we've got a state program interacting here, they don't always play as well as they should. So it could be the case that even though your beneficiary should qualify for a Medicare savings program, their LIS may not be active yet. the quickest way to rectify that is get that application started through SSA.gov or at the local Social Security office. And if all those things are in place, they are now eligible for a D-SNP. Now, I should mention that LIS is not necessarily a condition of enrolling in a D-SNP. But what often happens is that when someone enrolls in a D-SNP without their LIS being active, that member often gets charged a premium for the supposedly $0 pre-SNP, D-SNP rather, and they're paying the full cost under that plan for their drugs because that LIS isn't kicking in to pay for that portion yet. So that's a really big clue as an agent, right? That their LIS isn't active is if you get that D-SNP enrollment done, but all of a sudden your client comes to you and say, hey, I have a Part D bill for my D-SNP carrier for $38 or something of the sort, whatever the national premium happens to be. That's a big clue that something is wrong with LIS, and that's something that you'd want to take directly to the Social Security office or SSA.gov. So, a big thing we want to check for understanding here, quick yes or no. Is it possible for someone to enroll in a Medicare savings program without being on Medicaid? Just need a quick yes or no. Are you with me? Are you not? Okay. And again, if you're saying yes here, thank you for agreeing, everyone here. Thank you for the capital agreement here. Yeah, we can't make this point clear enough. Carrier reps, even when you're talking to people on service lines, they confuse this more than they should. The better question is what Medicare savings program are they enrolled in? Mrs. Gomez, what do you have to add to it for us
It
here
kind of
today?
reminds me of what we're going to talk about next week with the veterans care thing. If you are, they're organized into specific groups there with their um, veterans benefits, and oftentimes they're not going to know what like level they are in, but they can tell you what their copays are, right? Which that can tell you what level they're in. So this is kind of the same thing. Like they might know that they're in Medicaid, your client, but you may not necessarily know what Medicare savings program they have. And this is kind of the same idea, where like those things don't always necessarily make themselves as clear as they could be. And you'll see in the next slides how what program they're in is going to define what plan they are able to sign up for. So you're going to have clues along the way, but that's kind of I think why these get confusing for clients sometimes and for carriers as well because the items feed into each other, but they don't always necessarily become the same answer. And sometimes you have to work backwards to figure out where you're going with that client and with their Medicare savings program or their extra help or whatever, right?
Yeah. Yeah, I've worked, pretty closely with a few of you on cases and figuring out, what the right plan could be and what they're eligible for here. And it's always a puzzle, right? You're always picking up the clues. You feel like Batman or Batgirl, as the case might be, trying to figure out what exactly makes sense here and what's going on. So let's talk about those Medicare savings programs, plus one category that sits outside of Medicare savings program, but you'll see it everywhere, and so you should probably know about it anyway. Um, we mentioned that income and asset tests are used to determine eligibility for a Medicare savings program. So what counts toward those asset tests? Funds in checking, savings, or retirement accounts, stocks and bonds. So anything that's near liquid, right? If you go back to your economics, your macroeconomics courses in high school or college, your M1 and M2, anything that they can reasonably spend and have ready to spend within a week or so, anything that's near liquid counts as an asset for this case. There are some things that don't count toward their assets, and that is their one family home, one car, one burial plot, up to $1,500 in burial expenses, the furniture within their home, household and personal items, and any SNAP benefits they may be receiving. SNAP benefits won't count as income in this case. The other things won't count as assets in this case. So Medicaid, when they're looking at, or the state Medicaid agency, because we're not talking about Medicaid exclusively, but the state Medicaid agency is the one who determines where you go here. The state Medicaid agency takes a look at the assets minus those things. and figures out what your beneficiary may be eligible for. This is a big chart, but it's an important chart. I highly recommend that you screenshot this one either here or when it comes up later today. And of course, we'll send you a recording um, a bit later on here today. Let's talk about how the general thresholds for these programs here. We'll talk about FBDEs, full duals. This is the program that sits outside of Medicare savings programs, but it is a one way to qualify for D-SNPs here that we'll show you in a bit. If you are a full benefit dual eligible, your income is generally SSI income here, or Social Security income, whether that's SSDI or regular SSI. Your resource limit is $99.50 or $14,910 for a couple. Those folks do get, some states do pay for their Part B premium. In Michigan, we do. Those folks are cost share protected in some states, meaning they can't be balance billed or can't be billed for the portion that Medicaid would cover here, and they do receive full Medicaid benefits. As we go further down the chart, when we talk about qualified Medicare beneficiaries, and we're going to go in more detail on some of the slides here, these are also full duals here. They are their income limit is somewhere below the 100% of federal poverty level for their household size. You see the resource limits are the same, but those folks are eligible for Part A premium assistance, Part B premium assistance, cost sharing, and cost share protection for Medicare costs they might see here, but they do not receive full Medicaid. And we'll talk about the distinction here in just a moment. I won't read the rest of the chart to you here, but just know that I wanted to give you some time to take that screenshot here. We're going to go in some more detail on the upcoming slides here. So those QMBs, about 1 in 8 Medicare beneficiaries qualifies as a QMB. So you're going to run into these folks, 1 in every 8 clients that you have that could be eligible for a D-SNP. These folks do get help paying for their Part A and B premiums. They also get help with their Part A and B deductibles and any co-insurance they'd be responsible for, or co-payments they'd be responsible for under Parts A and B. However, QMBs only cover months going forward. So if you apply for it in March, your effective date for that program is April 1. You would only get help paying for your Part B premium April 1st and beyond. It would not help you with anything retroactive. Your monthly income limit here is 100% of FPL. Plus $20. That's the personal allowance that Medicaid agencies give folks. And the resource limit that we captured from the last screen is $99.50 in assets or for a single, or $14,910 for a couple. QMB Plus is another flavor of QMB. The difference is they also meet criteria for full Medicaid coverage in their state. And the plus is the big giveaway that tells you that they have full Medicaid and they're getting that green Medicaid card from the state here. Generally, they're going to qualify for full Medicaid by one of 2 ways. They are going to have an income threshold that puts them, firmly below this 100% of FPL. Or they'll have what's called a spend down, which is in Michigan at least, is a monthly deductible that they'd have to meet before their Medicaid benefits activate for the month. So they would need to spend down their income, spend down their assets in order for their Medicaid coverage to be effective. If you're a QMB, you also get, whether you're a QMB or QMB Plus, to be clear, you also get protection against bills for Medicare covered services through Medicare providers. They may still be subject to a Medicaid copayment if, as the service is covered by both programs. But generally speaking, these folks are protected from balance billing. A provider can't come after the beneficiary for something that Medicaid did not pay, or excess that Medicaid did not pay. These folks also get automatic with an asterisk here, extra help for Part D. So you know that they have a $510 max for each generic, $1265 max for each brand drug, and 0 drug costs once their drug spend hits $2,100. That includes all drug payments, so even those made on behalf of the Part D Extra Help program. Um, a quick illustration of that is, say you have a beneficiary that is uh, taking some tier 5 special treat drug, right? The most they'll pay per fill for that drug is $12.65, but Extra Help is covering the rest of the list price of that drug. So both what Extra Help and what the beneficiary pay both count toward that $2,100. Once those amounts total $2,100, they've met the out-of-pocket maximum on Medicare Part D for the year. SNPs are special or specified low-income Medicare beneficiaries, or SLMBs. You'll hear people often talk about them as SNPs. Program only pays for Part B premiums if the member is enrolled in both Parts A and B. The difference is it can have a 3-month look back applied to it as well. So big difference, right, between Quimby and SLMB. Quimby is only forward-facing month. Quimby can help with your Part B premiums for the past 3 months before you applied here as well. So if I was eligible because my income was between the Quimby and SLMB limits, so up between 100 to 120% of FPL, and I applied here in March, I could get retroactive assistance with my Part B premium. It's actually April. I can get retroactive assistance with my Part B premium up to 3 months. Same resource limit applies here for all programs, $99.50, $14,910. SLMB Plus looks like, feels like, sounds like the same. They meet their criteria for SLMB eligibility, meaning their income and assets fall into these ranges here. And they meet the criteria for full Medicaid in their state. Generally, again, they're going to qualify for SLMB by either meeting that standard outright or through that spend down that we talked about earlier. SLMBs are also qualified for Extra Help. Again, that should be automatic as soon as they are enrolled in the SLMB MSP. However, in cases where it's not automatic, never a bad idea to also start that application alongside. Quick check in though, what does that plus designation mean? For example, what's the difference between SLMB and SLMB plus, or Quimby plus? What's different? What does that plus tell you? What does it communicate to you here? And if you are telling me that it tells you that they have full Medicaid benefits in their state, you are correct. That matters a lot when we talk about D-SNP eligibility later on. Generally, Quimbys and SLMB only, so without the plus, are likely to have a spend down. There's also not a ton of them in Michigan. We'll show you some market research in 2 weeks from now. But that plus designation is huge. It's your clue that they qualify for full Medicaid and have more D-SNP options available to them. There are some other options, other Medicare savings programs to be aware of. These are increasingly less common, but that doesn't mean you'll never run into them. So let's talk about them here as well. Qualifying individuals, or QIs. This program pays for their Part B premiums if they're enrolled in Parts A and B. The income limit goes up to 135 here. So if that SLMB limit was 120% of FPL, now here I have another bracket on top of that. I got to make somewhere between 120 to 135% of FPL to qualify for this program. Same resource limits apply. But this program is funded a little bit differently than its friends, which we'll talk about in the next slide, because I want to remind you that QI qualifiers here also should be automatically enrolled in Extra Help for Part D. QI does sound a lot like SLMB, but QI, this qualified individual program, only covers the current year. So yearly renewal is required for this program, and states approve this on a first come, first served basis until funds run out, with preference given to previous enrollees. The difference in the funding is the QI program is funded by block grants from the federal government and with whatever the state's able to contribute here as well. Usually it's a matching block grant. And it's this extra pot of money kind of set aside for those folks who fall in this specific income range between the 120 to 135. It's not doesn't have the same federal dollars attached to it as the MSPs do, or the other MSPs do. We should mention that if someone does qualify for Medicaid within their state, any level of Medicaid benefits within their state, they can't get the QI, so there is no QI plus category here. If someone tells you they're a QI plus, that's your first cue that you need to go check their eligibility in whatever software that you are able to, whether it's a carrier portal, whether you're calling us, whether you're using Coverage for One powered by Sunfire. QI Plus does not exist, and tells you that you have a little bit of work to do in educating and helping out this member. There's also QDWI programs, or Qualified Disabled and Working Individuals. This program does help for Part A premiums if someone's subject to them, and there's a very specific set of circumstances where this happens. Say a beneficiary has a disability and was collecting or was on Medicare due to that disability, but then returns to work. Well, if you return to work, you can't collect SSDI, right? If you cross that working hours threshold. And if you're losing SSDI and you're premium-free Part A because you return to work, well, now you're on the hook for the entirety of that Part A premium, whatever portion of it, matches the working hours that you've done so far. These folks are not eligible for Medicaid. Their monthly income limit is anywhere between 135 to 200% of FPL, up to 40% of FPL with some income disregards. So we all know that Part A premiums are really expensive. You're in the $540 a month neighborhood there. This is really designed to help folks who were disabled, returned to work, and now are stuck with this giant Part A premium that they can no longer afford without a little bit of help. That's who it's meant for here. So quick recap of where we went. We talked about FBDEs, full benefit dual eligibles. They didn't get their own slide. It's not a Medicare savings program in its own right, but you will see them talked about when we talk about D-SNP eligibility. The other programs, we have QIMBY pluses and SLIMBY pluses, which are also full duals. We see every other program here is a partial dual, and that distinction between full dual and partial duals is really important going forward to know what level of benefits they have, because that dictates what D-SNPs they may be eligible for. Let's check in real quick though. How would you describe the differences between QMB, SLMB, or QIMBY and SLIMBY, and QI and QDWI? What sticks out to you as something you'll need to take away going forward?
I haven't been being quiet just because I'm good at being quiet. We know me. I have been looking at that question about whether or not they can have multiple vehicles. And the answer is probably. But keep in mind if you have like I don't know what are those called? Bugatti, they might want you to count that as an asset. And recognize that this is going to depend on the state too. There's some states where if you can count it as a working vehicle, that's going to change whether or not the married couple's allowed to keep multiple vehicles. But even if they do find that your vehicle is not like a reasonable is the word they kept throwing around there, you would be able to count it as an asset. Just know that that's then going to affect the amount of assets you're allowed to have, and you might have to take from another under quote asset portion of your asset web to be able to keep the vehicle. So sorry, I was doing a deep dive.
Mute. Sorry. That's quite all right. So as we talk a little bit about some of the differences here, what's popping up really is, in addition to all these here, is check out your Quimbies and Slimbies and their cost share protection, right? And this is what makes the difference when we're thinking about whether or not a D-SNP is the right fit, is your Quimbies and your Quimby Pluses and your FBDEs are cost share protected, which means they will not pay anything for any Medicare covered service. Same thing for Slimby Pluses here. Your QYs and QDWIs don't get help with both Part A and B. They get help with one or the other, and they're not cost share protected. They're still responsible for the costs associated with Medicare covered services, which impacts what we'd want to enroll them in. To apply for MSPs, I've said this a few times, but just so it's here in black and white, you can apply via your local branch of Department of Health and Human Services at michigan.gov/MIBridges. And we'll even have a little brochure for you that Chelsea can put in the chat for us here as well. While we're here, again, as well, when we're talking about extra help, just a reminder that it's not a Medicaid program, but any Part D enrollee making within 150% of FPL, up to 150% of FPL is eligible. Eligible beneficiaries can again apply through SSA.gov or their local Social Security Administration branch. Let's talk real quickly about extra help and spend downs, though, because here's where things can get a little muddy. If someone receives extra help when they're Medicaid eligible, if they are become eligible for extra help in the first 6 months of the year, they'll have extra help for the rest of that year. If they become eligible for extra help in the last 6 months of the year, they'll have extra help for the remainder of that year plus the next year. Extra help can also be a double-edged sword when we talk about spend downs, right? And that's that monthly deductible that someone needs to hit before their Medicaid benefits truly become active. Remember that extra help decreases the cost, the beneficiary's premium cost of Part D coverage, decreases the cost of their out-of-pocket costs for Part D drugs that they fill as well. So that spend down is a medical spend down. And when they're using extra help to purchase their drugs, they're only paying up to $12.60 per prescription fill toward that spend down because the spend down only reflects their actual out-of-pocket spending. That extra help can slow down their spend down spending. So when there is someone that does have a spend down, right, and we were hoping to take care of that with prescription drugs, if they're also eligible for extra help, that you're not going to hit that, which is a clear sign, or you're not going to hit that without spending a ton of money and getting a bunch of care at least, which is a clear sign that this person that does have a spend down should probably look outside of a D-SNP and look for something else because their Medicaid benefits won't activate in time where it makes sense that they'll be able to use the D-SNP. But we'll spend some more time with that in a few weeks from now here as well. Really, the carriers we want to, or the Medicare savings programs we want to dive in here today are the ones that are offered on the market to here in Michigan, your FBDEs, your Quimbies, Quimby Pluses, Slimbies, and Slimby Pluses. When we talk about D-SNP eligibility in Michigan, that's generally who we're talking about. There's a few that will cover QYs and QDWIs. In fact, I'll show you one a little bit here later on here today. But generally, we're talking about these first 5 categories here. Let's check in with Jane real quick. She's 36. She worked for 10 years, and she's been disabled for 24 months. She will enroll in Medicare beginning next month. She currently receives both SSDI and Medicaid benefits. She comes to your office interested in a D-SNP plan. What steps do we need to help her take to help her become eligible? Yeah, and we're chiming in exactly right here. Probably she's actually okay here, right? Probably a lot of this stuff happens automatically, but we need to verify that it has happened. We need to verify she's enrolled. She's got enrolled in a Medicare savings program. We need to verify she's enrolled in LIS. So how do we do that? Well, you can call your friends here at Action Benefits. We can check it out for you. You can also check it out in carrier portals like Humana or UHC. You can also check it out in Coverage for One, powered by Sunfire, and then take a look at what she is eligible for from there. When we talk about D-SNPs, again, we should point out that folks should be enrolled in Parts A and B, or must be enrolled in Parts A and B. Eligibility for D-SNPs is often limited to those 21 plus. So if you're under 65 and eligible for Medicare, generally speaking, most D-SNPs do limit that eligibility to 21 plus. Of course, you've got to live within the planned service area. As soon as you qualify for the D-SNP means as soon as you have that Medicare savings program enrolled, you can enroll at any time via an SEP, but plans can limit their enrollment to certain categories of Medicare savings programs. Who actually pays for care? And this is where we get into some of that behind the scenes work here. Know that Medicare or the MAPD in this case is always going to pay first when you have a dual eligible. So even if someone you have that's not in an MAPD, Medicare is always going to be that first payer. So Part A and or Part B will pay first, or the MAPD will pay first. Medicaid is always the payer of last resort. They're always going to pay secondary, which means, from a practical example, if you have a D-SNP member who goes to see an in-network PCP, maybe an annual visit for a cold or the sniffles or whatever, a level one office visit. Suppose there's a contracted rate of $100. Your beneficiary has no responsibility because two things are happening behind the scenes. Medicare or the MAPD is paying 80% of that Part B service, and generally your person without Medicaid would be responsible for the remaining 20. For your dual eligible, Medicaid's picking up that remaining 20%. For out-of-network care, which is possible if you have a decent PPO, although these are getting fewer and farther between with the advent of high D-SNPs here in Michigan, your beneficiary could see an out-of-network specialist, for example. Maybe they're going to go see someone at U of M that's out-of-network with their, maybe they're seeing a heart specialist or whatever that's out-of-network with their current D-SNP. So they're going to get out-of-network care. In that case, the beneficiary would again have no financial responsibility because the plan would pay their out-of-network co-insurance, whether it's 50%, 60%, 70%, whatever it happens to be, and Medicaid would pay the balance of that. So really, how does that work and what do you look for in practice? I'm going to lean on our friends from UHC here because they have a plan that does accept partial duals. This UHC Dual Complete MIVOO1, the HMO-POS D-SNP, we can give you some clues about how this plan will work. You'll notice first here, and I'll take this away in just a minute, that this particular plan enrolls FBDEs, QIs, QIMBs, QIMB Plus, SlimB, SlimB Plus. So almost every category that we talked about earlier, other than QDWIs. And of course, it tells you that someone needs an SEP to enroll. If you're a full dual, you have no cost sharing. So if you're an FBDE, pardon me, a QIMB Plus or a SlimB Plus, you have no cost sharing, and no premium on this plan here as well. So you see that their Part A and Part B services are covered with $0. Partial duals, though, your SlimBs, your QDWIs, and your QIs may have responsibility for Part C, D premiums or their copays under this plan. So you notice that the premium here is either $0 or 20 cents. LIS, if your beneficiary has it, will take care of that 20-cent premium. If your beneficiary does not have LIS, because maybe they're a QI and they haven't applied or whatever the case might be, they're paying that 20 cents per month here for this plan, which doesn't break the bank necessarily, but it is a premium charge. They'd also be responsible for select copays on this, and UHC makes this really friendly. You can choose their LIS level right up here to see exactly what their cost sharing would be according to their LIS level here. So I point that out just to say that full duals will have a different, two different people could have different experiences on this plan. Full duals would have no cost sharing, no premium on this plan, while partial duals would have some responsibility for what Medicaid, their Medicaid program or their LAS does not pick up here. So uh, something to keep in mind going forward. If a beneficiary is enrolled in a plan but does lose their Medicaid at some point through the process, they do get a 6-month grace period while their eligibility is reevaluated. Their D-SNP coverage pauses here, so their Medicaid coverage pauses here, even though they nominally have the D-SNP still in place. But the beneficiary is going to end up paying the Medicare cost sharing during those 6 months, unless and until they can requalify for the Medicare savings program that they were in. If they are unable to prove that for 6 months, they simply don't take any action, they'll be automatically disenrolled from their uh, D-SNP at the end of 6 months and have an SEP for new coverage. We should point out, though, that if they do lose their Medicare savings program here at first, this is also a trigger for an SEP, and often a good strategy there is to use that opportunity to get them into a $0 MAPD, so that way they have less of that 20% cost share. Facing here, they're only paying the plan's cost share there rather than the full 20% they might otherwise be responsible for. And then if they are able to requalify, you can use that SEP that they would get for requalifying for Medicare Savings Program and put them back in the D-SNP where they might like to go. Let's talk about Carla here. She's a beneficiary in the Quimby Plus MSP. She enrolled in a PPO D-SNP, which is open to both full and partial duals. Her plan documents note that the plan covers out-of-network specialist visits at 70% coinsurance. How would we explain Carla's financial obligations for an out-of-network specialist visit to her or a caregiver? What will Carla owe after this visit? And why? I suppose is a good question as well. Chelsea, you've been quiet a while. What's your best guess here?
Oh, sorry, I accidentally clicked the pencil. So
Yeah,
that plus there is telling me a lot. She has Medicaid and Quimby. So I would say that she doesn't have, like, she can't pay for, she wouldn't get any cost sharing on her part because Medicaid would pay for the rest of it, right? So she wouldn't have any.
exactly right. So as long
Yes.
as she's in a PPO D-SNP and Danny's right here too, she'd have no cost sharing responsibility for seeing the side network specialist as long as she's in that PPO D-SNP. HMOs do have their own network restrictions. So be mindful of that going forward. But you hit on all the right things there. She's Quimby Plus, which means she has no cost sharing responsibility for a Medicare covered service. She goes and sees that specialist. She will not have any financial obligation here.
The specialist might try to send her a bill. And that doesn't mean she should pay it. Like that's the other thing I've noticed with my own personal experience with these. Like the provider doesn't always understand that and they're
Mhm.
not financially incentivized, I guess, to understand it. They're going to want to get their money, right? Which is understandable. They might just send the bill just automatically, not recognizing this person is a plus. So if you have a client that gets one of these, always, 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 always tell them don't pay the bills, which makes me anxious and would make that person anxious too. I get it. But don't let them pay those bills. Like make sure they understand that Medicaid will eventually pay them. Just the provider might be quicker on the draw than Medicaid is. Well, I'm going to say probably quicker on the draw than the provider is. And the provider's going to just whip out a bill really quick. Don't let them pay it.
Yes. Which, yeah, it causes me anxiety here too, right? Don't pay the bill. I'm a type A personality with like my 820 credit score, right? I have to pay the bill. Um, Now you know way too much about me. But the don't pay those, right? It's illegal to balance bill those beneficiaries. It's illegal for them to ask them to pay things that they're not liable to pay. But too many providers just don't know or may not care, right? If we take the worst possible interpretation of that as well, they're just looking to get paid, as Chelsea pointed out. A few bits and bobs for you before we go here. What about prior auth? So services on a DSNP are subject to prior authorization, but it's not quite as sticky as prior auth on a regular MAPD. Once a service is approved, approval is valid for as long as the treatment is medically necessary. There's no additional approvals required. So as long as the doctor says, yeah, they need to keep taking this medicine like forever, the carrier cannot legally, um, come back in that unless the carrier has a really good argument to say why it's not medically necessary. And then you've got providers and carriers fighting, which is not always a great look. But know here that prior auths do work a little bit differently than they do on a regular MAPD. The other thing here is continuity of care. If a beneficiary does switch to a new plan while being treated, they have at least 90 days before the new plan can require their own prior auth in the same service. So if, for example, I have someone being treated for, dialysis, right? They have ESRD. They switched D-SNPs at the end of the year. They switched D-SNPs at AEP. New D-SNP goes into effect on January 1. That D-SNP has to keep paying for dialysis, right? Has to keep, and all related services through March of that year, at least that, before they require their own prior authorization. So to help really make sure these vulnerable people are still taken care of. We should also talk a bit about coordination, and this kind of builds on what Chelsea said earlier about the providers and Medicaid not always talking with each other. Michigan currently does not limit D-SNP enrollment to plans that also have a administer Medicaid benefits or have an MMCO. But Michigan D-SNPs do have to follow federal standards for care coordination. So the D-SNP really is in charge of steering this member's care in a lot of ways. They have to notify both the state of both hospital and SNF admissions, and the D-SNP is your point of contact if Medicaid doesn't end up paying something, or you need to appeal something from Medicaid that Medicaid didn't pay, or you need to ask where a Medicaid bill is or where the status of Medicaid claim. The D-SNP is actually a point of contact there. It's not whoever has the Medicaid coverage at the moment, whether it's the state or a private carrier. The D-SNP is where you go. But what about HIDE D-SNPs? So MI Health Link transitioned to Michigan Coordinated Health, or the MISH plan, in select counties on January 1st, 2026, and state will complete that transition on January 1st of 2027. What does that mean? Well, currently, if they are in regions 1, 8, 10, or 12, Macomb, Wayne, the Southwest Prosperity region, which is Berry and Cass, those sorts of counties, or any upper peninsula county, they're currently in what's called a highly integrated dual eligible D-SNP. What does that do? A few things. It does integrate long-term services and support. So these HIDE D-SNPs do have to include at least 180 days per plan year of nursing facility coverage, which is a new benchmark for them. Behavioral health does remain separate under that program, but it does vary in other states. The other thing that we should point out there is that if you have a beneficiary living in one of these and living in one of these areas, and they enroll in a HIDE D-SNP, their Medicaid enrollment will follow them to whatever Medicare carrier they choose. So if, for example, I have a beneficiary in Wayne County, for example, Priority Health administers both D-SNP and Medicaid benefits in Wayne County. If they were to enroll in Priority Health's D-SNP in Wayne County, they'd have those Priority Health D-SNP benefits. Priority Health would also get the Medicaid. which makes coordination of claims a lot easier, right? Priority will know who should pay first, who should pay second. Your beneficiary only has one ID card to deal with now, rather than one for their Medicare carrier, one for their Medicaid carrier. It gets a lot easier for that case, and that's the vision that the state has for 2027 that we're still on track for. It's also colors into some enrollment decisions that we'll talk about in a few weeks from now here as well. One last check here before we get ready to go. Suppose one of your D-SNP clients is taking a medication to address heart failure. That medication, of course, requires a prior auth because they don't give out tier 4 drugs all willy-nilly. This AAP, she wishes to enroll in, with another D-SNP carrier with a richer OTC benefit. What can you tell her about how the plan will treat her heart failure drug? What must they do, and what should we look for going forward?
Oh, I did it again. I clicked on the pencil instead of the microphone. They need to quit putting that pencil so close to my microphone. But anyway, I don't want to give away the answer, but I always think about this too. The prior auths, if you change plans for something as important as like a tier 4 drug, it always sounds so scary to me, but I guess it really wouldn't be because if you have that level of heart failure, if you're going on dialysis, you're seeing providers enough where I would think and hope that that prior auth wouldn't be too terrifyingly difficult to obtain after that 90 days. Oh, yes. Okay. Someone put it in the chat, so I wasn't giving away the answer. Okay. Whew.
Yep, exactly right. She'd have continuity of coverage for 90 days. Am I unmuted? I am. Okay. She would have continuity coverage for at least 90 days here, but the plan may require a new prior auth after that. So just be ready for that. Exactly right here. So we've talked a lot about the guts here today in these 51 minutes here together. We talked a lot about Michigan's guts here and where the market is going. And to be clear, this session is designed to be more informational, educational. Doesn't and really in the space of an hour, that's as much as we can fit into an hour here. Just giving you the background here on these programs, how they work. For more information, again about like how do I make a decision? Where do I actually put these people? We do invite you to register for our session 2 weeks from now. It's going to give you some better clues around that. You're always welcome to talk to us. You can find us at LinkedIn at the Action Benefits Company, email Chelsea and I at learning@actionbenefits.com, or reach out to us on our main line, 248-356-8585. And whoever's answering the phones there will be happy to send you to the person that can help you with the particular problem you're facing. Chelsea, before we open it up to the floor for any questions they have, anything on your mind we need to share?
No, I did learn a little bit more about what it means about a community person in comparison, community spouse in comparison to a regular spouse. I was looking up all that stuff just now about whether or not you can have a car. It opened up a whole new can of beans. So I'm excited to go learn more about that. And fortunately or unfortunately for you guys, you might get a whole new webinar about community spouses coming up in the future. But thank you for joining us today, learning about all this stuff.
For that said, on behalf of Chelsea, on behalf of everyone here at Action, thank you all for joining us here today. We look forward to seeing you again at another Action Academy session. Please enjoy your days.